Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Amy Sanders. She's a neurologist, and today's Kevin MD article is How Biomarkers Are Advancing Dementia Detection and Care. Amy, welcome to the show.
Thank you so much, Kevin. It's my pleasure to be here.
So let's start by briefly sharing your story and journey.
Well, my story is actually a bit unusual because when I finished college, I didn't go to medical school. I went to graduate school at Columbia University and was going to be an historian of modern Western Europe. I got as far as passing my orals, and when I had to become sort of self-sustaining, became harder and harder and harder for me to convince myself that people would really, really be interested in how Otto von Bismarck used the Prussian railway system unification as a way to begin unifying Germany. It's a really good dissertation
Mhm.
topic, and I hope somebody writes it someday, but it was not for me. When I had first gone to college, I had been pre-med, but I had been very, very, very bad at it. So when you get a D in organic chemistry and you get another one in calculus, they don't let you go to medical school. So then I became a history major and went to graduate school in history but I couldn't sustain it. So then I had to have a very, very long think about what am I going to be when I grow up. I was in my 30s by this time. And I decided I'm going to go full circle. And Columbia had a post-baccalaureate pre-medical
Mhm.
program. They let me do that. I got one medical school to accept me. That was all it took. And when I went to medical school, I knew that I was going to be some kind of doctor from the neck up. And I was not going to be ENT. No offense to ENT practitioners out there, just was not my scene. The neck anatomy, so complicated, way over my head. So it was either going to be psychiatry or neurology. And at that time, I was very, very, very captivated by things that were tangible. And neurology has all of those pathways. And I just ate that up. But then I wound up becoming sort of the most psychiatrically oriented neurologist you've probably ever encountered because my area of specialization in neurology is cognitive decline and dementia. And in neurology in general, there's a big, big overlap with psychiatry. But I think in my area of neurology, that overlap is perhaps at its most notable. So that's sort of my story.
All right. And you wrote this Kevin MD article about how biomarkers are advancing dementia detection and care. For those who didn't get a chance to read your article, tell us what it's about.
Yes, so it is about biomarkers, which have been around for a very long time in dementia. That is new. So I am currently working for a telemedicine dementia practice called Sunday Health. It's based out of Washington, D.C. and in that area. And we see patients, older adults, with cognitive decline and dementia. That's how I have always practiced, mostly in academic medicine until recently, and now I work for a startup. But the issues are the same. And for most of my career, and I began practicing in 2008, for most of my career, dementia neurology was kind of this quiet little backwater. We didn't have disease modifying treatments, and we looked jealously at multiple sclerosis because
Mhm.
they had all these disease modifying treatments. And we didn't have great biomarkers that we could use to track disease. So we were jealous of the epileptologists who had a lot of medications. And it just we just didn't have much. We had counseling. That's pretty much what we had. Now things are completely different. We have disease modifying treatments,
Mhm.
the initial ones, and we have biomarkers that now, and this is what's so exciting, are going to become less expensive and more accessible. So a biomarker, that just means some sort of biological entity that we use to measure physiological activity in the body. So every time you go to your doctor's office, they take your blood pressure. Well, that's a kind of biomarker.
Mhm.
They may check your hemoglobin A1C, the famous test that sort of assesses how sugary one's red blood cells have been for the past 3 months. That's also a biomarker. In dementia, for a long time, codified in the 2001 American Academy of Neurology practice parameter for evaluating older adults with cognitive impairment, we have always been instructed to check some basic sort of screening labs, a vitamin B12 level. Too high, not a problem. Too low can cause all kinds of mischief, including cognitive impairment. And we check thyroid function. Too much thyroid makes people very anxious and jittery. Too little thyroid can cause cognitive impairment. So those have been, we've done that for ages. But what does that do? It tells us that there's no metabolic issue that we could ameliorate to make things maybe a little bit better. But it didn't tell us anything about the diagnostic processes that were going on.
Mm-hmm.
For a long time, we have had PET imaging that can look at both amyloid and tau, can see them both. Amyloid is now minimally clinically available. You have to sign your patient up in a registry in order to get an amyloid PET. Tau PET is still in the purview of research. CSF examination for biomarkers has been around for a long time, but it requires people to have a lumbar puncture.
Mm-hmm.
And that's typically now done in the interventional radiology suite. So then they also get a nice hefty dose of ionizing radiation. Wouldn't it be better if people could just go and have a blood test? And that is now what we have, sort of. We're in the nascent phase of this, but we can now check to see if people have genetic markers that increase their vulnerability to developing Alzheimer's disease. We can check to see whether there's a clinical hint that they are depositing abnormal amyloid protein into their brain tissue, because then that amyloid protein is less visible in the peripheral circulation, and we can do a blood test to check for the ratio of abnormal to normal amyloid protein. When that ratio drops, we think it means that people are depositing amyloid protein into their brains. We can check for several different isoforms of phosphorylated tau protein. Now, and here, so these tests are frequently referred to in the internet, the Google space, the digital Wild West, as diagnostic tests. That's a misnomer a little bit. They certainly help to clarify my diagnostic thinking, but they are not per se diagnostic, or at least we don't understand them well enough yet for them to be per se diagnostic. But what they do is give us a much more precise picture of what is going on. So if somebody has elevated levels of both p-tau 217 and p-tau 181, those are the ones that are most commonly checked these days. There were many others, but these are the two that is sort of the cream that has risen to the top. If those are elevated, it probably indicates that there is also amyloid pathology going on. And then there are two additional tests that we can now assess that help us get a sense of whether there is neurodegeneration. For example, I saw a gentleman the other day who I think has vascular dementia. I sent him off to have all of these labs drawn because if they come back essentially negative, that will reinforce my clinical thinking that he has vascular dementia, which, by the way, is the only non-neurodegenerative dementia. So I expect, for example, that his level of neurofilament light chain, which is sort of a general marker of neurodegeneration, I expect that to come back as normal. So biomarkers are the advent of biomarkers is incredibly exciting because it increases the precision of our diagnostic thinking, and they're going to be much more accessible and much less expensive. All boats rise.
Now, as a neurologist, what are the clinical scenarios that would make you order some of these blood-based biomarkers? Someone I send to you as a primary care physician who I think may have Alzheimer's dementia, and now that patient is in front of you. Where do these blood-based biomarkers enter the diagnostic approach in your mind?
Right. So that's an incredibly important question, and thank you so much for asking it. The biomarkers, the Alzheimer's specific biomarkers, really should not be used in a screening fashion. So the thinking these days, and is probably that specialists like me are the ones who should be ordering these biomarkers. There is a school of thought that says that internists, primary care physicians like you, should also be ordering them, but they should not be used in a screening fashion. So they should be used once there's some evidence that somebody has cognitive impairment. And then you can sort of use them both to confirm your diagnostic thinking if the profile comes back in an with an Alzheimer-like appearance, or to confirm to rule out a possible Alzheimer's process, which can be equally important. These tests are not quite yet accepted as sufficient evidence to establish somebody's eligibility for one of the disease modifying treatments. For that one, probably is still going to need a confirmatory PET scan or CSF analysis with a lumbar puncture. But the first step, being blood tests, is certainly always more accessible and less expensive.
So, as a neurologist, you would have to have a clinical diagnosis first of some type of neurodegenerative
I would have to have
dementia.
a clinical suspicion
Okay.
that I want to work up.
And if these blood-based biomarkers come back positive, and then what would your next step be given a positive result and your clinical suspicion of a neurodegenerative source of dementia?
Right. The path, there are several pathways forward from me getting a positive biomarker result. And a lot of it depends on the patient. So the patient is always the most important person in the room, and the decision making should be a shared process. So if the patient sort of looks like they might have mild cognitive impairment due to underlying Alzheimer's pathology or the mild stages of Alzheimer's disease, they would be preliminarily, at least on the surface, eligible for monoclonal antibody therapy. Those are the new disease modifying therapies. The blood based biomarkers would be suggestive, but not sufficient for them to become eligible in most places. So not every place manages their use of the monoclonal antibodies in exactly the same way. But in most places, one would then have to go and have a confirmatory amyloid PET scan or lumbar puncture. And then if that also ruled them in, then they would be eligible for monoclonal antibody therapy. If the patient is not interested in that, and I have maybe one patient who is emerging as possibly interested, and that's all so far. But the counseling that I can then give to a patient and their care partner and their loved ones becomes much more precise. That yes, I think this is Alzheimer's disease based on your clinical history and your clinical profile and the results of your neuropsychological testing. And now I have this biomarker analysis that really sort of bolsters my clinical impression. So I can then talk to my patients from a position of, yes, this is probable. This is what we think this is. And knowledge is power for people. So when I think that when, just as I was all about things being tangible when I was transitioning from being a graduate student to being a medical student, I think when patients have tangible information that they can grab onto, that can really help them adjust to their new diagnostic situation.
How accessible are these tests? Is this something that you can order at most labs?
Yep. Quest has each of the labs that I would order available. You sort of order them a la carte. LabCorp actually has something that they call the ATN profile. So A stands for amyloid, T stands for tau, N stands for neurodegeneration. And I think you can order the ATN profile at LabCorp. As it happens, thinking about this, I realized that I always order them piecemeal, sort of a la carte. But yes, these are now widely available. I don't think that they are on the menus of tests that you can just walk into a Quest or a LabCorp and request. They have to be ordered by a physician.
And you mentioned several blood-based biomarkers. You mentioned phosphorylated tau as one of them. How many blood-based biomarkers are we talking about? And do they select to different forms of neurodegenerative dementia, or how different are they in terms of what we're measuring?
Right. So you can think of them in a couple of different, if you will, buckets. So there's a genetic test that we now often run. For most of my career, the teaching was you don't check somebody's apolipoprotein E status because if it comes back as that they have increased risk, we don't have anything to offer them. Well, now we have stuff to offer, so that test is being run much more frequently. So that's a genetic marker. Then typically the amyloid ratio, which is a direct assessment of amyloid, but in an indirect way, because it's looking in the peripheral circulation to get the sense of what's going on in the brain. But that looks specifically at amyloid. So that's a ratio of A beta 42 to A beta 40. That's been around actually for it's close to 2 years. That was sort of the first blood-based biomarker to which I had regular access. Then there's p-tau. P stands for phosphorylated tau 181, phosphorylated tau 217. These both look at isoforms of tau protein. The phosphorylated tau is at the center of the famous neurofibrillary tangles in Alzheimer's disease. But when we check them as biomarkers, we're actually getting a sense of sort of, is there active Alzheimer pathology happening? So amyloid is an extracellular biomarker. Tau tends to be intracellular. So that's a little bit trickier. One reason that at least in my thinking, that I like to have two values. And then we check glial fibrillary acidic protein and neurofilament light chain. GFAP, that's glial fibrillary acidic protein for short, is actually a better biomarker in the plasma than it is in CSF. That can be a very, very early marker that it's a marker of inflammation and that people are starting, that something is beginning to happen. And the NFL, neurofilament light chain, that's a marker of neurodegeneration. So that's sort of the corpus of biomarkers that I run when my question is, do I think this is underlying Alzheimer's pathology or not? But this is a really, really active space. And slowly but surely, biomarkers for other neurodegenerative conditions are emerging. We can now do skin biopsies, skin tests, for example, in certain types of Parkinsonian syndromes. So a lot of activity in this area of neurology, which makes it it is no longer a dusty, quiet backwater. We are downtown, midtown Manhattan these days.
Do you feel that in the future there's potential for some of these biomarkers to be used more in a screening setting? Is that something that you see on the horizon?
That's a good question. And the short and truest answer is I don't know. I suspect that eventually we may have the equivalent of a hemoglobin kind of A1C, the earliest possible marker that something is happening. I don't think we yet know which of those markers that might turn out to be, but I think that's an entirely likely scenario in the future.
So, as you know, I'm a primary care physician. If a patient comes to me reading about these biomarkers in, say, the New York Times and wants me to order these tests, what should my answers be? What should some of the questions I should ask next?
Right. So I think that it would be important to ask about whether that patient has any symptoms. Is there a profound family history? So if the patient has any symptoms, then I would say, as a primary care physician, I've never practiced as a primary care physician, so I'm sort of, experimenting with my imagination here. But I would imagine that I would say to somebody, that look, we are not using these biomarkers for screening purposes yet. If you have symptoms, then we need to examine those symptoms before we make a decision about biomarker testing. If, however, somebody has a very, very profound family history, that maybe yields a different conversation because then you might at least want to check their APOE status, although you probably wouldn't want to do the other biomarkers. However, I have had patients come in and, we had one who came in and presented to us and said, "Hello, Sunday Health. I would like you to run my ATN profile." That shocked me. That was several months ago that somebody already knew even the jargon, the lingo about how to describe these blood tests. So that does happen. In her case, we eventually did order it, but she also got the full workup. And then I would say it would be a good idea for you to have a cognitive neurologist. I'm gonna age myself here, but on the equivalent of whatever the digital modern equivalent of speed dial
Mhm.
is, to have somebody who's working with these biomarkers on a daily or near daily basis, who you could call up and say, "What the heck does this mean?" Because we're sort of all learning how to interpret these markers.
And just to be clear, as of today, we're speaking in November 2024, you do not see a role for these blood-based biomarkers to be used in most primary care settings. Is that fair to say?
That is fair to say as my opinion. If you had somebody else on your podcast this morning, there's a very good possibility that you could get a very different opinion because there are two schools of thought.
We're talking to Amy Sanders. She's a neurologist, and today's Kevin MD article is How Biomarkers Are Advancing Dementia Detection and Care. Amy, let's end with some of your take-home messages that you want to leave with the Kevin MD audience.
Sure. If you are a clinical practitioner who sees older adults with cognitive impairment, know that these biomarkers are out there, that they can help you, but you may want to access the services of an expert who can help sort of guide you as you begin to experiment and learn about these biomarkers. For everybody who's listening, I cannot stress enough how important brain health is. Yes, it's great that we now have disease-modifying therapies and that we have biomarkers, blood-based and otherwise. But there is so much that you, the individual, can do to protect your own brain. You get EKGs and echocardiograms for your cardiovascular health. You get colonoscopies. For the love of all that is holy, please get a good brain health examination and talk to your physicians about how best to protect your brain. We know a lot about how to protect the brain, but medicine as a profession has not yet done enough consciousness raising to spread the word. So I've planted a seed. Please get your brain health examined.
Amy, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
My pleasure. Thank you for having me.